And may I now invite our next speaker, Dr. Reema Bansal. Dr. Reema Bansal is a consultant in retina and uvea service at PGI Chandigarh and a distinguished speaker with a huge amount or volume of work in infectious choroiditis. So thank you for joining us, ma'am.
A very good morning, all of you, and thank you, Mudit, Padma, Malika, and Ankush, and thank you, AIOS and Scientific Committee, for having me in the subspecialty course. So the topic given to me is infectious choroiditis, serpiginous, and beyond. And if you carefully see, I'm sandwiched between known speakers on retinitis, and the next speaker is going to be talking on pattern recognition of choroiditis. So for me, it was difficult to know what exactly I'm expected to speak on. So I thought of putting up, my material on what I believe would not be covered in the subsequent talks in this subspecialty session, and something that I'm sure all of you are not aware of. So when you talk of, choroiditis, involvement of the choroid, it could be choroiditis or it could be chorioretinitis. Now, from what you've seen in the previous talks, most of the retinitis may or may not be associated with choroid involvement, and hence the term is like overlapping between chorioretinitis or retinochoroiditis. So for that, I thought I'll just stick to choroiditis in these few minutes. So when we talk of serpiginous, the word the etiology that comes to mind of all of us is, of course, tuberculosis. So the moment you talk of serpiginous choroiditis, you think of talking of TB, because here we're talking of infectious. Had it been non-infectious, we could go on for autoimmune causes of serpiginous. So here we're not talking of that. So I thought I'll take you to various etiologies that have been reported in serpiginous choroiditis when it comes to infectious agents. So first, we all know about the TB being the serpiginous-like choroiditis among the serpiginous choroiditis with TB as the etiology. So there are a couple of case reports highlighting the involvement of SARS-CoV-2, herpes virus causing serpiginous choroiditis, toxoplasma, fungal, and others. So TB, we all know, this term was coined in 2003 by Dr. Vishali and Dr. Amod Gupta, and where the involvement of serpiginous choroiditis due to TB was termed as serpiginous-like choroiditis. The importance of this term is that it has a very typical phenotype. It has a very good response to the antitubercular therapy, and the recognition is almost instant when you see these patients in your clinic. So these lesions are typically multifocal. They have a serpiginoid extension. And we also know that many of you and many of us who have seen this etiology have recognized MTB from the eyes of these patients. This is the classical presentation of these tubercular serpiginoid choroiditis. It's a very classical phenotype. The autofluorescence is very classical, and this is how it heals clinically as well as an autofluorescence. We also know that some of these lesions have a tendency to come back, maybe in the form of a paradoxical worsening or in the form of a recurrence. So paradoxical worsening is, we are all very aware of it. It happens. It's a well-known entity. And you may have positive Montaux, you may have involvement on the radiological imaging, but even if you don't have these positive radiological imaging, you have the clinical phenotype in front of you in an endemic setting. I think the diagnosis is not really difficult. And this is how it heals, with exuberant pigmentation all around the fundus, with the classical foveal sparing. Even if this kind of pigmentation is there, we have these patients spared with 6/6 or 6/9 vision. Now, the problem comes when we don't have TB as the underlying etiology, and many of us would not even know that there are reports of the herpes virus causing similar type of presentation. So this was a publication on 9 patients with serpiginous choroiditis, where they did PCR from the aqueous tap of these patients with active disease, and they found five were positive for VZV, 1 for HSV, and 3 were negative. So this is, if you look at the clinical presentation, very similar to the tuberculoid. So you have this serpiginous choroiditis here, but the etiology is viral and not TB. So we need to keep this in mind from this publication. And another case report of a viral etiology of causing serpiginous choroiditis, where this was a 57-year-old black woman who had, because the authors felt there is a link of viral etiology with this entity, and this is what they found, a typical brush fire appearance of the serpiginous choroiditis, and this was also complicated by a choroidal neovascular membrane. So a complication like CNVM is well known in serpiginous choroiditis. So here again, a herpetic or a viral etiology was the cause of serpiginous choroiditis. With the COVID, this entity again got a new etiology with the SARS-CoV-2, and this was the first report of this virus being the etiology of serpiginous choroiditis. Whether it's an infective trigger or an immunological trigger still remains a question to explore, and this is how they found that this infection, the patient became symptomatic just 1 month after the COVID infection. So this is the classical presentation of this patient that they reported. You can see the active lesions on clinical appearance, how they are seen active on autofluorescence, and of course confirmed on the angiography. Toxo, we have the report from Dr. Padma Malini's group, not very well known, but I think we all should be aware of this possibility as the cause of serpiginous choroiditis. So this was the classical presentation. You can see the lesions in the posterior pole, in the mid-periphery, and even in the inferior periphery where you can see active lesion. The fluorescein confirmed the window defects and the active lesions. So this was basically a 32-year-old. Again, the background sometimes is similar between TB and non-TB etiologies. You have a 32-year-old male where the serology from the blood was positive for toxo, and the PCR confirmed the toxo from the aqueous humor. Now, when you talk of infectious non-tubercular serpiginous choroiditis, I found these two reports in JAMA, where the two very rare causes were explored and reported by the authors. Now, this was the first case where the patient had hunting as a hobby, and after testing these patients for the known causes for general for TB and syphilis and all that, they tested the patient serologically for Francisella tularensis, and they found that this serological testing was positive. So the authors attributed, now if you look at why I've put up these pictures is, if you look at the clinical presentation, the phenotype is quite similar to what we talk of serpiginous-like choroiditis. So here they found this serological testing positive, and this was again a rare cause of serpiginous choroiditis. The patient was treated with ciprofloxacin and responded well. The second case, again, if you look at the clinical presentation, the right eye has serpiginous choroiditis lesions in the posterior pole, very well seen on autofluorescence and fluorescein angiography. This patient had Montaux 18 millimeters. So to begin with, the diagnosis was tubercular serpiginous choroiditis. The patient received ATT, but after 3 months, there was a new lesion in the left eye where you can see in D, E, and F. So they tested the patient again. The serology for Bartonella Hensley was positive. The patient received moxifloxacin and then responded well to this. So these were two case reports of very rare infections as the cause for serpiginous choroiditis. And again, there is a series where they have pointed out fungal etiology from patients of serpiginous choroiditis and patients of azure. Now, the important is that the authors, they haven't given the reason for why they suspected fungal, but they tested serology and they tested the PCRs from the blood samples, and they found positive reports of various species of candida from the blood of these patients. So what they did was they tested the serum or the whole peripheral blood. They checked for the fungal growth in the appropriate media. They also tested the antibodies, again, different candida species, by immunofluorescence. They tested the fungal genomes by quantitative PCR, and antigens from Candida famita and other yeasts were tested by the slot blot assays. So to summarize, when we talk of infectious serpiginous choroiditis, of course, we have tubercular etiology as the first possibility and the first thought. But from these anecdotal case reports, we do have to keep things in mind. But of course, after ruling out the most common, depending upon the clinical setting, depending upon the population, depending upon the patient, from which geographical the region the patient comes from, and if there is no definitive evidence, it needs a very careful interpretation. So thank you very much. And with this, I invite you all to the Silver Jubilee of USI 25th Annual Meeting at Chandigarh in October. Thank you very much.
Thank you very much, Dr. Bansal. Thanks a lot for